you are all energetic and we are going to learn a new procedure which is majorly a life-saving procedure, I would say. Before going into the procedure, I would like to give a scenario behind it. So imagine that you have been working in an emergency room and you are the staff nurse there, and you get a case where they are walking and coming and suddenly the patient is collapsing himself and falling down onto the floor where attenders and the securities have holding him. And immediately as a nurse, what is our response? Anyone from the group? Yes, you please. The patient is collapsing and lying down on the floor. But he has not any fault because the attender has holding him. So as a nurse, what is your response? Okay, one is saying vital signs, the other one checking the consciousness, very good, it's great answer. Then checking vitals. Oh, I will give applause for everyone's contribution, but the most priority we will go with this answer, that is checking the conscious level, because it is not necessary immediately you go with the vitals. Whenever a patient is falling down, might be there is some reason why the patient is falling down. It is not only due to cardiac arrest or due to respiratory arrest that the patient is collapsing. Might be it is due to some other reason, such as might be his glucose level is down, his BP level is down. As you said, vital signs through BP, assessment of blood pressure, we will be able to know whether he is in hypertension and so on. So the first measure is that checking the level of consciousness. So today, yes, we are going to say about a life-saving procedure, which is the basic life support. Are you aware why they call it as basic life support? Yes, try the answer. So here, the basic life support is nothing but we are going to give some forceful interaction to the patient or intervention to the patient, or might be a client. It is not necessary the patient only should get the basic life support. Anyone, might be it is a common person who is working in and out of you. Might be you are going to a restaurant, you are eating, someone is being having some big hamburger and might be a burger, choking up and suddenly falling down. So, or might be on the roadside, sudden road traffic accident, patient is unconscious. So, this is a major thing, that is basics of all the procedures, where even a lay person can do the procedure. Lay person in the sense, we call it as like not a non-medical professional. Anybody can do. Anybody can do. It can be a manager in a hotel, or it can be a housekeeping person in a hotel also. So anybody can do this basic life procedure. So why we call it as basic life? That is, we are going to see only the two major vital organs, which is very very essential when compared to the all other vital organs. That is the heart and the lung. So that's the reason we call it as basic life, because without air you cannot live. Without the blood circulation, if there is decreased blood supply to the brain, patient will be recovered, but there will be total brain death. So that's the reason we will be checking for the we call this as a basic life support. Support in the sense of this resuscitation procedure might revive the patient. Revive in the sense it may bring back the patient to life, or we cannot help it. My patient is having so many comorbid conditions. Patient is having lung failure, liver failure, or might be some cardiac virus like coronary artery diseases, diabetes, hypertension, with so many comorbid conditions. Those patients also we cannot help. So only we call it is a support. Before an emergency aid or before anything is done, it's giving as a support, and it is preventing so many complications as well. Complications, what complication can occur when you delay the procedure? When you delay giving CPR, what can happen? What do you think from your aspects? Patient can go for death, you say. Okay, then unconsciousness will be there for a longer time. Good. Then patient can go for a critical situation like whereas He may need some ventilator support and so on and so forth. So all these will be the major factor. So we call this procedure as a basic life support, where it can be done anywhere, anytime, by any person. So these three concepts we keep in mind. It can be done anywhere, not only in hospitals to be performed, no, on a roadside, on a restaurant, on a theme park area, or maybe on hotels, anywhere, anytime. There is no specific time limit. For example, vital signs monitoring in the ward, maybe within each shift you will do. But in CPR, you don't have any fixed time. Okay, this time 8 to 9, I'll go and give bed number 7 CPR. Do we do that? No. So it can be done any time. And it can be done by any person. But advanced cardiac life support, ACLS, it is a different concept where we are going to use other technologies as well as we will be using emergency drugs. But it should be done only by us. It is the medical professionals. But here the basic life support can be done by any person. So coming to the next sequence, that is sequence of CPR, or we call it as the steps of CPR. To easily remember for us or any person, we at the American Heart Association have given some sequence. So we will see each step how to do and how to do. So we all know that CPR is cardiopulmonary resuscitation. So what is cardio means? It's going to deal with the compressions of the heart. So which is going to improve the circulation of the client who has fallen down. And then pulmonary. So pulmonary is leading to, or it's giving us an idea that we are going to give some external air and we are going to enable the lung function to enhance back due to sudden respiratory arrest as well. And resuscitation. Resuscitation is nothing but bringing back to life by doing some maneuvers. Maneuvers is that you are going to do some external manipulation of the patient and then bring back to normal. So now the first step of basic life support is check for response. Okay, immediately you can't go and immediately lie down and start CPR. That's not the way. Because I told you there can be other conditions like hypoglycemia or hypotension. The patient will be having some sort of 1 or 2 minutes of unconsciousness. So for those patients, if you do CPR unnecessarily, it's not going to help them. Okay, instead the patient will be going into anxiety and fear. Why suddenly this nurse is going on, bouncing on my chest, they will feel that. So what is the thing is checking for response. So how do you check the response? So you have to be very louder enough because patient is collapsing and his auditory senses are not that much intact. So you have to shrug the shoulders and say just, are you okay? Are you okay? Are you okay? In a louder tone, shake the shoulders. Don't go and just simply touch. Are you okay? That's not good. So very louder enough and shrug the shoulders. Are you okay? Sir, are you okay? Sir, can you hear me? Something you have to communicate. Because he is unconscious. We don't know what is the name of the patient. So just shout Mr. or Mrs. by saying sir, madam, you call them with respect and then shrug the shoulders. So these are the shoulder area where you want to shake the shoulders enough and then shout it loudly. If no response, then we go to the next step, that is checking for the circulation and breathing, not less than 5 seconds and not more than 10 seconds. So in AHA, American Heart Association, what they have told us is that this seconds they have done one research. We don't have time, stopwatch. Okay, I'll do it seconds. 1, 2. No, you can't waste time by looking at your watch. So instead, they have done so many evidence-based researches where they gave a coining of word 1001. 1001, 1002, 1003, 1004, 1005. So 1001, when you tell that word, is equal to 1 second. Okay. So you can use the 2 or 3 fingers, that is the index finger, middle finger and the ring finger of your dominant hand. If I am a right hand dominance, I use my right hand. If you are a left hand dominance, use your left hand. So use your dominance hand, put your 3 fingers onto the carotid artery. You may ask me one doubt. Why, ma'am, I should go and touch onto the coronary artery, carotid artery rather than on the peripheral artery? Peripheral artery is on the limbs. Any guess why I am going on with the feeling of the carotids on the neck when compared to the leg?
Near the heart.
Near to the heart. Okay, then very good answer. Then one more concept is, I'll tell you. Here what is happening? The heart function is going to lessen or it is slowing down. So when the heart is slowing down, is the cardiac output very efficient? No. Cardiac output, what is the definition of meaning? The force of the blood being ejected to all the systemic circulation. So this systemic circulation is totally impaired or cut off. So that's the reason we are not going for peripheral, because peripheral arteries will be on collapse. No use, you are wasting the time. So immediately you have to go in for 1001, 1002, checking the feeling the pulse, as well as you have to put your cheeks onto the patient's nose. Why near the patient's nose? Okay. Might be his breath, if he is having a good proper respiration, his warm of air can be, or chill air can be felt on our cheeks. So okay, why do we use the cheek? I can use the other hand. Do you ever thought of that? Any who is going to give the response? I can use my hand, toss him up here. But instead, why he is a victim and I am the rescuer? Why the rescuer have to go and see like this, as well as feel the respiratory sounds? Very good, excellent. Then one more thing. The thing is that we are having so many sensors, receptors, which is easily sensing in our cheek. Anybody who touches your cheek or who pinches your cheek will be more painful when compared to the peripheral skin. The skin is more sensitive on the cheek area, and we can easily, the rescuer can easily identify what's happening in the patient. So that's the reason we use the cheeks when feeling the patient's respiration, as well as the sounds of the respiration, and we can also see the raise of the chest. So three things we are doing simultaneously. Not only three, four. One is senses, we are touching and feeling. The second one, we are hearing the respiratory sound. The third one, we are feeling the respiratory breath of the patient or of the client. Then by seeing, by our eye senses, we are seeing the chest wall movement. Okay. So if the patient is in gasping in the sense, he is not, or he is going into respiratory arrest, which is easily seen that there will be abdominal breath when compared to respiratory breath. Respiratory breath or the chest wall movement is a normal movement. But in case if the patient is going for gasping, you can see fine up and down of the abdomen. So that is really another, it's giving an alarm for us. Immediately start the call the anesthetist and we have to do intubation and so on. So you are checking the response for first one. The second one is immediately you activate the code blue. So activating code blue might be if it is inside the hospital. So what is code blue? It is a what do you say? Oh, it's a team for CPR. Okay, fine. Any other answers? Yes? You? Just try it. It's like whatever you tell, it's not necessary to be the right answer. Just try. Color codes or emergency. So it's nothing but in hospital we have so many codes where we have to immediately respond. So as I told you, CPR can't be done only by ACLS, can't be done only by one single person. So in those cases, we will be activating code blue, where it is, as you said, it is a team of members, where you have a cardiologist, an anesthetist for intubation, cardiologist for looking at all the rhythm and whether to give shock, whether to give adrenaline, whether to give atropine. All those cycles will be decided as well. It can't be run only by doctors. We need other persons. Who are they? The nurses. The nurses, 2 nurses will be on circulation side. It is only doing the compression. They will be exchanging themselves, nurse 1 and nurse 2. And the other nurse will be going only for the airway. So we call it as the airway nurse. And the third nurse will, the 4th nurse will be on IV access. So she will be started with the IV fluids and so on. That's the reason. And one more nurse which is called as the scribe nurse. Scribe is nothing but she will be noting down what are the sequence you are doing. Because in many of the emergency situations, what we do is that we think that we are right, but we may miss the steps. Or we don't know whether what is the reason the patient not been declared. What is the reason the patient have been revived earlier. One patient we did half an hour CPR, we couldn't revive. One person we gave only 2 minutes CPR, he revived. So we can do some data analysis also. So there will be one scribe nurse who won't do anything inside, but she will be just on the side, noting down who's doing what, and the sequence will be written down in that code blue sheet. So this is helping us, the nurses as well as the doctors, the other consultant professionals, to improvise or to maintain the same. If they are in a good progress, they will maintain the same sequence of CPR. If in the team member anyone is doing any mistake, that particular person can be sent for retraining. That's the reason why we have code blue. After code blue, then maybe if it is in an outside hospital, I told you, in a restaurant, in a theme park, in a hotel, in a temple, in a church, in a mosque, anywhere can happen. Patient can become unconscious. So what is that? You are activating 108. In India, we call the number 108 and immediately the people will care. But until then, you can't stay like this because we are all health professionals. Immediately, what is the next step? So you are checking for the pulse and respiration by the counts of not more than 10 seconds and not less than 5 seconds. So around 10 or 7 or 8 you can stop. So 1001, 1002, 1003, 1004, 1005, 1006. That is no chest one. Even we can tell up to 1010 also, not an issue. So why we are giving these least seconds is that the brain will be cutting down the blood supply if it is more than 4 minutes. There is no blood supply, there is total brain death. Some textbooks give you 3 minutes, some textbooks give you 4 minutes. But AHA, American Heart Association, has done the research. They found it is more than 4 minutes if there is no blood supply to the brain. Patient can go for brain death. You can give the CPR, you can revive the patient. Revive is, you can bring back the patient to life. But what happens? Patient won't be alive. He will be, the lungs will be working, heart is working, liver is working. But patient is very still. He will be in coma. So that's the reason we are not delaying the CPR. So only we are giving that sequence, 1001, 1002, 1000. So after that, you are checking the response. There is no chest wall movement. You can't feel the pulse. It is very, very feeble. You can't hear the respiratory sound. You can't feel the respiratory rhythm. Immediately, not wasting time, then you start the circulation, airway, breathing. So the next sequence of our BLS, basic life support, is circulation, breathing and CAB, airway and breathing. So why they have done circulation of the first? As I told you, all the tissues will be deprived with oxygenated blood. That's the reason immediately we are not wasting time. We are going to improve the ventricular filling as well as ventricular ejection. So you know the heart is divided into 4 chambers, right? Right side 2 and left side 2 chambers, where the upper is called as the atrium and the lower is called as the ventricles. And for systemic circulation, that is all the blood to receive, all the body to receive blood, left ventricle plays a major role. That's the reason we go for compression at the apex of the heart. Right? So here, how you will locate the area. So they are easily given you. Don't go for calculation of 15% space like going in a checking between the intercostal space. Instead, you can draw an imaginary line between the 2 nipples, and this is the area, but towards the lower side, not towards the upper side. Towards the lower side, you will be keeping your base of the hand dorsal and not the fingers. This must be done. Place both together. One should be totally clenched like this, and see that the elbows are straight. So if you feel if you are not, if the bed is too tall, if the bed is too short, or if the patient is collapsing on a restroom area, or might be on a pond on roadside, put him into a safe place, seat safety. So that is also very essential. Seat safety is for both, for the rescuer as well as for the victim. So once you have done the scene safety, then checking the pulse and respiration, no pulse, no respiration, then start CPR. So mostly in our hospitals what we do, we get onto the couch and we do the CPR. Why? In the sense, the force should come from the hip bone. The rescuer's force on the sternum, that is between the two nipples, should come from the hip bone and not from the shoulder bone. If it is going to come from the shoulder bone, maybe the third CPR, you will get drained. That's the reason we immediately cling on to the couch. So you can fold your knees and you can see, locate the area. You should not fold your hands. See that you are interlacing, interlocking, and then so 30, after 30, then you are going to give 2 respiration. So the first is circulation. So after circulation is done, you are going to go for respiration. So respiration, you have to clear the airway and then only you can do the breathing techniques. Why we should clear the airway? Yes, you behind. This is the airway. Airway is nothing but the passage from the mouth, external area, and then going into the larynx, then to the trachea, and then to the both the bronchus, and finally to the alveolus. So we are going to give this passage clearance. Anyone, are you aware why we need to clear the airway? Very good. That's the main reason. That is tongue form. So during the cardiac arrest or respiratory arrest, all the muscles are going for extreme relaxation, and because of that, the tongue is going backwards. You cannot hold the tongue like this by using a tweezers. No, it's impossible. So you have another technique where you are going to head tilt and chin lift maneuver. Head tilt is you are going to use your hands like this onto the patient's forehead. Now finger onto one side and the other fingers are covering the full frontal region, and the 2 index finger on the dominant hand to the chin, and you are going to lift it. It is nothing but hyperextension of the neck. So in this position, the tongue is being released and patient's airway are very straight. So see that even when you are giving the breathing air, that is the air, into the patient's mouth or to the nose, it should be like this. Even when you are going to give the respiratory breath also. So if it is done externally anywhere in the outside the hospital, you can use a gauze piece over the mouth and you can pinch the nostrils and directly you have to give the respiration. So how we give the respiration? The rescuer have to take in more oxygen. After you take in oxygen, then you have to 1, 2. Then again you resume the CPR. So maybe you do the extension of the neck, pinch the nostrils, take huge breath, then close the full lips and give breath. If not, you have nowadays the ambu. So if it is inside the hospital, don't panic. So because there is high chance for patient might have any infection. If you do mouth to mouth or mouth to nose, there is high risk for the healthcare worker to develop the infection. So immediately you can take the ambu bag and you can connect it to the O2 supply and you can use it like C and E technique. And see that you are not placing any pillow onto the patient's head. That's not necessary. So this is C is compression of the mask. So you hold your fingers like C, compression of the mask, tight sealing, then E. These 3 is E, you are doing the extension of the mask. And when you are doing, you give 1000. Immediately you have to place it and there is no response, immediately you have to resume the C. Right. So after that sequence, this sequence will be going on for 1 minute. How many compressions we can give is that? 100 to 120 compressions, and the breath is like you are going to give for every 30 seconds loudly when the CPR, the circulatory nurse is giving compressions. Then for every 30 compressions, 2 breath will be given. On the other hand, another scenario, a pulse is there, you can feel the pulse, but there is no respiratory movement. What we can do? We can go for the next step, which is giving rescue breath. Compression is not needed because pulse is very, very accurate and you can feel it very easily. So for those cases, might be patient is in respiratory arrest, not cardiac arrest. For those cases, you don't need to give CPR or waste time by giving only the compression. Only we need this amber bag for rescue breaths. So this rescue breath, like approximately for every 6 seconds, you are giving one breath. So totally you will be giving 10 to 12 breaths for 1 minute. So you can hold it. In case if there is only respiratory arrest, pulse is there, no respiration, then you give extension of the neck, C compression, and extension of the neck, and you give 1000, Why we give in that sequence? You cannot go for very fast. 1, 2, 3, 4, 5. If you do very fast, what happens is air will be gushing very fast because near the trachea you have another passage also. What is it? Esophagus. So of course, very good. So through the esophagus, also air will be entering and patient's abdomen will be bloated, distended. If the abdomen is distended, what happens with air? Air will be pushing the diaphragm. And the diaphragm is pushing lungs as well as the heart. Cardiac filling will be now interrupted. So indirectly we are giving harm to the patient. So you don't give it very fast or too slow. If you give too slow, no oxygenation to the alveolus. If you give very fast, abdominal pressure will be increasing, throating of the abdomen, which have direct impact on the heart as well as to the lung. That's the physiology behind why we are not doing very fast. The other one, that is compression also, I am not going very fast. If you see me, I was going like 1, 2, 3, 4, 5, 6. Why in the sense, we have to allow for chest to recoil. You can't do like this. That's not it. To do that, either low filling or might be cardiac output is very reduced during this physiology. So you have to allow for chest recoil. That is, whenever you push, should recoil. So how much depth we can push? 2 to 2.4 inches, or it can be in centimeters, 4 to 5 centimeters depth you are going to push, and no fast. That is, you have to push hard and push fast. Push hard in the sense the depth. Push fast in the sense how many thing you are going to do. That is for 1 minute, 100 to 120. Allow for chest recoil as well as allow for the patient to have the respiration in a sequential manner, not pushing very hardly through the lungs. So after that, if the patient is regaining, the pulse is regaining, respiration is regaining, then you again you reassess. Both are very exactly good. Patient is responding, and put the patient in recovery position. And we have to be closely monitored because just now the patient had undergone cardiac arrest and respiratory arrest. Anytime he can have the other attacks as well. So that's the reason we have to closely monitor and plan accordingly. According to the consultant, we are going to be planning the management, whether he needs cardiac intervention or whether he needs respiratory intervention. And if still patient is not regaining, then we have to start with the ACLS. So ACLS we will be seeing in the next class. So now I wanted you to form as a team. One will be doing the airway. Can I have it? The airway nurse? Please come forward. Who's going to do? Can you do? So you will be the airway nurse. You will be the initial nurse, that is at conscious you are calling and alarming them. Okay? 2 circulatory nurse, that is compression, please come for compression. And 1 nurse for recording the treatment. I will help you out. That is a client. You have gone to a bakery and you are having tea. The patient, while having tea only, is just falling onto the chair. As a nurse, you are near to the client. As a nurse, what will you do? Check for response.
Are you okay, Mr. Kumaraswamy? Are you okay?
Okay, he is not okay. He is on the chair. As a nurse, what will you do the next step? Scene safety. No, scene safety. That is, he is on the chair. So you put it on a flat surface. He is on a flat surface. What's the next step? So the third step is assessing for the pulse and the respiration. Come down. So your eyes should see for the chest wall movement and your ears must feel for the respiratory sound as well as for the cheeks must feel for the respiratory breath. Are you able to feel the pulse, respiratory sound, respiratory breath, chest wall movement? As a nurse, what do you do? So this count must be done within what I told you, 1001, 1002, not less than 5 seconds and not more than 10 seconds. Okay, there is no pulse, no respiration. What is the next step? Start CPR. Yes, CPR nurse, circulatory nurse. So which is the area? So between the two nipples, between the sternum, lower half, not on the upper half. So you put laser on that. Yes. 5, 6, 7, 8, 9. You have to be louder. The last 30 when you sound, then she will be allowed. Oh, I have to get ready. So we should not waste time. And the next is, after the compression, we are going for the, see, if you are going to use your hand, this hand, C and E technique, and this E technique, extension of the neck, and this should be the this. So you are going to get breath, rescue breath, 1001 and 1002. So after that, 1002, the other circulatory nerves must be ready. Start the CPR. Should not waste it. So this will be going in sequence. You should not waste this gap. No, this 2 seconds is also a great thing for the patient. We will miss the patient. The last 30 when you are coming, please be louder, so that the team member will be known and she will be getting ready. Yes, please. So, yes, this head tilt and cigarette maneuver can be done for all the ground. But there is a case like you have cervical fracture, lumbar fracture, or any spinal fracture, especially neck fracture, neck injuries, or any facial injuries and neck injuries. You cannot do head chin lift and head tilt maneuver. Instead, we will be going for jaw thrust maneuver. That is, you are going to open the jaws even wider, and you are going to do the compression of the lung. Okay. So, okay, pulse is now regained. What you will do? Respiration is still on. Give the rescue breath. So that rescue breath will be given 6 seconds, 1 breath. So totally in 1 minute, 10 to 12 rescue breaths will be given. And once the patient is regaining, you can put it into the recovery position. So if the patient is not regaining, when we can stop the CPR? Anyone from the group? Yes, yourself. Come forward. Going and hiding yourself. When we can stop the CPR? Yeah, when there is, we call it as spontaneous respiratory breath. Okay, spontaneous respiratory breath and spontaneous pulse is the, then we can stop the CPR.
No response after CPR.
No, imagine you are going on with the CPR for more than 30 minutes. You are totally exhausted. When you do the ratio or analysis, the first CPR and the last 30th minute CPR will be totally reduced. No use of it. So when the rescuer is totally exhausted, we can stop the CPR. Then, and we can stop the CPR. In spite of all the measures, you have started with ACLS, no response. Still, you feel the cardiac monitor showing flat inline, that is asystole, and we cannot continue the CPR will be stopped. So, three major aspects. One is the patient is reviving. The other one, when the rescuer is totally exhausted. And the last condition, when the patient is having so many comorbid conditions, that reviving is very, very less even after giving so many measures like defibrillation and as well as giving emergency drugs. So that is when even when after ACLS is totally going for failure, then we have to stop the CPR. Okay. So this from this, are you now thorough with the CPR? Will you be able to go for any person on the floor is falling down? On the list, we will do that.